2, 1. We are live.
Evening to all of you. On behalf of Indian Society for Cornea and Cataract Refractive Surgeons, welcome you all in this webinar on a very common condition related to a very common surgery and related to a surgery which is bread and butter for every ophthalmologist. I mean, most of the anterior segment surgeons. And that is complications of cataract surgery. We have with us our president of ISCRS, Professor J.S. Tityal, who is also the chief of RP Center. He is known for his academics, for his publications, for his numerous awards that he has received, both internationally and nationally, numerous orations all over the country. He was the first Indian to have performed a live cataract surgery. Of course, he will be one person who will definitely give us great input in this particular field. And he has also received the most coveted Padma Shri from Government of India by the President of India, which is a big honor for all of us, for all the ophthalmologists, for ISCRS as well. So we welcome our President, Tityal sir.
It is a pleasure to welcome Dr. Rishi Mohan, who is going to be joining in very soon. He's a RPC alumnus, and he has, to his credit, a large number of awards, gold medals, both from his own alumnus as well as otherwise. And he has been into key leadership positions, which include the president of the Delhi Ophthalmological Society, and even at AIOS, the member scientific committee and the member managing committee of All India Ophthalmological Society. And more importantly, he is the vice president of our society, the ISCRS.
We also have with us Professor Namrata Sharma, who is the chairperson, Scientific Committee, ISCRS, and Professor of Ophthalmology in the Cornea, Cataract and Refractive Surgery Services at RP Center. She is also the secretary of AIOS, regional secretary of Asia Pacific Academy of Ophthalmology, secretary IBank, and has numerous publications, various chapters in textbooks, books that she has authored. She is a wonderful academician and a great teacher, and it is really great that she is with us in this webinar.
Thank you, Rajesh. It is a pleasure to welcome Dr. Meenu Methan, Senior Consultant, Chaitanya Eye Hospital from Trivandrum. He's truly a teacher and a trainer in cataract and microsurgery. He was a trainer in cataract and microsurgery at Arvind Eye Hospital, Madurai. His specialty is cataract and refractive surgery, and he has, to his credit, many awards on surgical videos. He's participated in many live surgeries and has many instruction courses at the national and international level. And of course, he's a great academician and a teacher, and it is always a treat to watch his beautiful videos and surgeries. Welcome, Dr. Meenu Methan.
Thank you, ma'am.
It's great pleasure to welcome a dear friend, Dr. Harshul Tak, who is Director and Chief Surgeon, Rawat Eye and FECO Surgery Center, Jaipur. And he's also Director, Jaipur Laser Vision Center, Chairman, Scientific Committee, Rajasthan Ophthalmic Society, Member, ARC Central Zone, Assistant Editor, IGO and Cataract Session. He is also Executive Member, IRSI, and Governing Council Member of Indian Society of Cornea and Cataract Refractive Surgeons. He is immediate past Secretary of JOS and past Central Zone Representative of FBS AIOS. And he's also, of course, the state representative of FBS AIOS for Rajasthan, and he was the chief organizing secretary of Glaucopedia in 2017. He has won numerous awards. He has coined the term hydroimplantation in ophthalmology and published the article in Journal of Cataract and Refractive Surgery. He has been awarded Shurveer Singh Gold Medal for the best paper presented at Kota in 2008 in ROS meeting, and has been awarded Surya Narayan Gold Medal for Best Video Film at Jaipur 2010 Annual Rajasthan Ophthalmic Society Conference. And he is again a wonderful surgeon and a very good academician. We welcome Dr. Harshul.
Thank you so much, sir.
It is a pleasure and honor to welcome Dr. Harbanslal, who is presently the Director of Delhi Eye Center, Vice President of All India Ophthalmological Society, Co-Chairman Department of Ophthalmology, Sir Gangaram Hospital, Chairman Department of CME, Sir Gangaram Hospital. He has done more than 100 live surgical workshops in various national platforms like DAWS, AIOS, various state societies and medical colleges for the last over 2 decades. He has, to his credit, several instruction courses in AIOS, DAWS, and other state societies, again for the last more than 2 decades. He has a large number of publications in peer-reviewed journals, and to his credit, he has many firsts, both at the level of DAWS and AIOS, as far as the leadership role is concerned. His book on phacoemulsification, Text and Atlas, is the most read book in the country for mastering the technique. And his two other books, A Guide to Phacoemulsification and Management of Posterior Capsular Tear, were distributed to all the eye surgeons of the country through the All India Ophthalmological Society. So welcome, Dr. Harbanslal, sir.
It's a great honor and privilege to welcome Dr. Lalit Verma, who is currently the President-elect AIOS. He is also Director, Retina Services Center for Sight, New Delhi. He has done his specialty training from RP Center. Initially, he did his MBBS from AIMS and then MD from RP Center, and then did his senior residency from RP Center, became consultant here. He did his Vitreoretina fellowship from USA. He was consultant at AIMS for 14 years. He has close to 200 publications, 38 theses, research projects, various awards and orations, invited speaker in many more than what is written here, because he is one of the most sought after speaker in every conference. He has been past Chairman Scientific Committee, General Secretary and Honorary Treasurer of AIOS. And he has also been past President and past General Secretary of DOS. And he is a person who has loads of ideas. He keeps helping everyone. And most importantly, he is my teacher and my thesis guide as well. So it's great honor and great pleasure to welcome Dr. Lalit Verma.
Thank you, Rajan.
It is again a pleasure to welcome Dr. P. Ellen Kumaran, who's done his MD Ophthalmology from RP Center, AIMS, Delhi, MBBS from Bangalore Medical College and Research Institute, Bangalore. He's been a fellow and he's done his senior residency in cornea, cataract and refractive surgery services, in fact, from RP Center. And it was always a pleasure to work with him. Currently, he's the medical director at Navashakti Netralaya, Bangalore. He has extensive experience in operative procedures such as topical phacoemulsification, ECCNIOL, SICS, corneal transplants, refractive laser and non-laser surgeries, glaucoma surgeries, squint surgeries, DCR, lid surgeries, and retinal detachment surgery. He has, to his credit, various papers, instruction courses, and talks as invited faculty at national and international platforms. He has various publications in national and international peer-reviewed journals, and he's currently the Vice President of Bangalore Ophthalmic Society. It is always a pleasure to interact with Ellen, and we welcome you, Ellen. Always a pleasure to see your presentations.
Thank you, ma'am.
We also have with us Dr. Rajesh Joshi, who is Associate Professor of GMC Nagpur with teaching experience of nearly 25 years. He is engaged in community training and research work. He is working in the capacity of zonal member and member scientific committee. His role in organizing MOSCON in 2013 and 2019 held at Nagpur was very significant. Currently, he is President of Vidarbha Ophthalmic Society and the General Secretary of Maharashtra Ophthalmic Society. He's also he has been Chairman Scientific Committee of Vidarbha Ophthalmic Society earlier and has many publications to his credit. He is the recipient of AIOS IGO Award and many academic awards at the state and national and international level, and has been awarded the best teacher at Moscow in 2019. And a very good friend of mine. It's great privilege and honor to welcome Dr. Rajesh Joshi.
Thank you, sir. Thank you.
It is again a pleasure to welcome our very dear friend, Dr. Ameya Kulkarni, young ophthalmologist from Sangli. He's currently Assistant Professor, Department of Ophthalmology, Bharati Vidyapeeth Medical College and Hospital at Sangli, consulting ophthalmologist and phaco-refractive surgeon with special interest in ocular trauma and community ophthalmology, cataract and refractive surgery, pediatric ophthalmology and glaucoma. He's passed out his MBBS from Krishna Institute of Medical Sciences, Karar, and his MS Ophthalmology from Pravara Institute of Medical Sciences, Loni. And he has a passion for teaching and surgical training. So we look forward to your deliberations in this webinar, Amey.
Thank you.
It's again a great pleasure to welcome again a dear friend, Dr. Sharvana, who has done his MBBS from Bangalore Medical College and Research Institute, Bangalore, and then did his MD Ophthalmology at RP Center, AIMS, and then his senior residency at RP Center in the Vitreoretina Services. And he is again a very good academician, very logical person, has presented various papers, instruction courses, and talks, has invited faculty at various national and international platforms. He has again various publications in national and international peer-reviewed journals. He is founder member of International Ophthalmologists Academy and is a consultant eye surgeon and vitreoretina specialist at Sri Venkateshwar Nethralaya. And most importantly, Sharvana is a very, very well-read person in terms of law, in terms of even IT, in terms of many things. So for many advices, people approach Sharvana. So we welcome Dr. Sharvana.
Thank you, Dr. Rajesh. Thank you.
So Sarvana can advise on things which nobody can advise actually. So we welcome our treasurer of the ISCRIS, Dr. Rajiv Mukherjee, Director and Senior Consultant, Mukherjee Eye Clinic, New Delhi, visiting professor at Feinberg School of Medicine, Northwestern University, Chicago, USA, a very established cornea and phacosurgeon, and has presented many papers and courses at the international and national levels, and is also the Vice Chairman of the FBS All India Ophthalmological Society.
So a very good evening once again to all of you. And before we actually start the scientific program, I will request our President, Professor Tityal, to say a few words.
Thank you, Rajesh. It's a wonderful beginning of this ISCRIS Friday, because Friday has become for us the Indian Society of Cornea and Keratoid Refractive Surgeons. And very, very happy and pleased that to see a topmost people of our country today joining us, starting from my dear friend, Dr. Lalit Verma, who's been a wonderful teacher for our entire country. And his teachings go not only to the topmost people, to the right, to the the new generation, and they all adopt to his way of teaching and learning. And Dr. Harbans Lal, who's been a wonderful teacher across the country, and I have learned so many things whenever I listen to him, and his book been I think one of the topmost books for people doing a post graduation. And like to thank both of them from my heart, because they've been with us not many times, but they've been regular with us also. Apart from that, I know that Harshul has a way of teaching. His videos have been wonderful. I always appreciate his videos, and their clarity, and the teaching videos are wonderful. And apart from being a wonderful person himself, he's very close to Uttarakhand also. And I appreciate his connection to us also. And Meenu, like I know him for a very, very long time. And Namrata initially introduced him being a wonderful teacher. His videos have been always teaching videos for everybody. And classical videos he has, and the way he goes around the country, and people appreciate his way of teaching. Today, we are definitely going to learn not only the normal usual things, but complications, difficult situation in cataract is always there, and it's with all of us. So we have to learn these things correctly and identify them and appropriately discuss. And for discussion, Dr. Rajesh has chosen a perfect panelist for us. Dr. Ilan Kumaran, Dr. Rajesh Joshi, Dr. Amaya Kulkarni, and our own Sarvana. So these people are going to make things lively for us. I'm pretty sure this session is going to be absolutely wonderful. Thank you, Rajesh, for organizing this session. Let's begin with the first interesting session. I'll say session because each one is like a session. Because I know that cataract surgery, we can write an entire book in one particular step. There's so many things to be told, and floppy iris prolapse is the most challenging thing in our routine cataract surgery. Let's begin with the most challenging part with Meenu.
Thank you, sir. So the first speaker, Dr. Minu Methan, who will be talking about repeated intraoperative iris prolapse, why and how to manage. Why it happens and how to manage.
Thank you, sir. I just started sharing my screen. Is it visible?
Yeah, it's visible.
Okay, thank you, Dr. Rajesh, Dr. Namrata Madam, Titial sir, for this invite. And the topic is iris prolapse and IFIS. So I have no financial interest in this talk. So let me start with some common causes for this. Let's look at the incision itself. So this is using a diamond blade. It's accidentally it was there in the OR, so I thought I should use this. So the incision is okay in length, but then if you notice, it looks slightly bigger. So now we realize that the incision is much larger than the sleeve which is put on this one. So whenever you use a sleeve, see what is the prescription by the manufacturer, what is the size of incision, and you get used to that, and then use precise sized incisions. Otherwise, the next thing to happen immediately after going in is visco going out and the iris following. And once this happens, the pupil keeps coming down, you keep shafting the iris and all those. So if this is there, one option is to put one suture at one corner and try to continue, but otherwise, if it doesn't stop, it is always better to abandon the incision and go to a new location and continue with your phaco. Also, a very short incision also can lead to repeated iris prolapse while putting in your phaco probe. And so I'm just measuring. This is close to 4 millimeters when this was a 2.8, around 3.8 millimeters when it was supposed to be 2.8 millimeters. So this is one important thing which we need to keep in mind. So the next point is fluid misdirection. So once we started surgery, at any point of time, the chamber can become shallow and it can become hard. So this is a situation where just after cortex aspiration, I usually do this irrigation of the posterior capsule with saline, and just to get off all the the cortex fibers which are sticking to the capsule, and then suddenly it started becoming hard, and AC became shallow. The PC was bulging out, but it was not very hard. It was not rock hard, and if you notice now, you can see that the iris is into the section. So if you touch on the incision, the iris comes out, and the chamber is just formed, but then the bag is not forming. So I just tried to put viscoat and then inflate the nasal part of the bag so that you get some space. Then I was looking for the red glow. This is a microscope which gives good red glow. So I could see good red glow, no disappearance of red glow, no progressive hardening. So at that point, we waited for some time. Many things can be done. You can abandon if you don't want to continue. You can look for, you can do an indirect, look for suprachoroidal hemorrhage or effusion, and you give mannitol on the table and wait for half an hour. But here, I'm just using a Sinskey hook to just withdraw the iris from the incision and then keep the incision tight with the nozzle of the injector, and then gently place the single piece IOL. 3-piece IOLs I would never place in such a situation. And the nasal bag I had inflated with the viscoat, and so it was forming and staying over. And after very mild and gradual push, we can nudge these lenses into the bag if the bag is forming. Otherwise, we may have to. Still, you can see that the iris is coming out, but still it was possible to form. This was a lucky day for me. So I was able to form the bag a little bit and then just nudge the lens piece by piece. First the leading haptic goes, then the optic goes, and then bend the trailing haptic and nudge it under the rexis margin. So we should make sure that the lens has gone into the capsular bag. And again, this iris, if you put more viscoelastic, it's going to come in. So use a blunt instrument to reduce the chamber volume and reposit back the iris, and then aspirate the visco. Here, it's better not to touch behind the lens. You tap on the lens, the whole thing comes out. There's no much space between the PC and the IOL at all here. And while coming out, stop irrigation and come out gently. Still, you may get the iris coming out. So here, the probability of a fluid miscorrection is the most probable diagnosis here, and that was confirmed after some time also. So the lens is in the bag, and after maybe a few hours, it will just like that form. So that is what happens with the milder fluid misdirection where you can manage. But most of the time, many of the times, we may have to abandon the situation. So coming next to the most common problem of intraoperative floppy iris syndrome. So in India also, we are having this kind of prostate, benign prostatic hypertension and hypertrophy, and people taking medication for that, it has become very common. So here the point is a mid-dilated pupil, in this case around 4.55 millimeters. So my incision, I make sure that they are not larger, and a two planar pucka incision, tight incision. So I put in xylocaine now, you can see the iris fluttering. So that is the first sign that it may become floppy iris during your procedure. So fluid going into the eye, making the iris flutter, is the one which you should, we should make us feel that is going to come down, and mid dilated pupil. So I make a 4.5 to close to 5 millimeter, not a large rexis. So little towards the smaller side, and a hydrodissection very controlled. Know that the cannula should not hit on the capsule or on the iris, and also there should not, the nucleus should not rise up. So now watch, I've started phaco, I've just taken out the epinucleus, suddenly see the fluttery movement and the billowing of the iris and the pupil becoming suddenly small. So now I take out the probe after stopping irrigation, that is very crucial. Still I have iris inside the incision, but it goes back out. So now I realize that I should not continue with this because I'll end up with problem. So the best thing is to get the iris away from your rexis area and to retract it towards the periphery and away from your incisions. So that is why I have one hook just underneath my incision and one hook very close to my paracentesis, because whatever iris you pull back, it may not become small, the pupil may not become small, but then the iris in the periphery can always come out through the openings. So here my procedure is routine, although you need to do slow motion phaco. I'll show you in another video when you do without iris retractor hooks, and then get the IOL into the capsular bag, and after that aspirate you can aspirate visco or need not aspirate visco, but after taking the hooks, if you try to aspirate it, it may again create problem, you will catch the iris and all. So hydrate the incisions, and I take out the last hook also, and then make sure that the IOL is well centered, and always aspirate under the iris also. Now after taking out also the iris comes in. So what I do is to reduce the chamber volume, and then tap back the iris rather than damaging the iris by retracting it with the mechanical instruments, and at the end I finish with Oromox. So this is again a similar case, a mid dilated pupil, it is less than 5, maybe close to just above 4 millimeters. So such cases I nowadays do not proceed, I just put iris retractor hooks or rings. So here I just wanted to show you the Indian version of the iris retractor ring, the B-hex ring, which is very polished now. This is, I have been using this from the time he started making this. I was one of the evaluators for it. He used to send all the different modifications which he used to make. This is one of the earlier ones which has only 2 holes. So these are this is a 6-sided one. So alternate flanges you just tuck underneath the iris. Nowadays we suggest only iris forceps, the micro forceps which comes along with this, and using a Sinski manipulator may damage the capsule. You can see there has been some touch on the capsule, but there was no problem. But then nowadays we use only forceps from 2 paracentesis here and through the main incision. Once that is done, again as I told you before, the iris is still there here near your incision and the paracentesis. So incision has to be according to the size of your chopper, and it should not be too leaky, and the whole iris can flutter. Billowing can happen when you irrigate below the iris, and even though the ring is in place, the rest of the iris can billow and it can have movement, but the pupil won't come down. Here you can see I am deliberately not using a second instrument during IA. So if possible, keep all incisions closed. So this will keep this incision also closed, and it will keep the chamber more stable without too much of fluttering. And after the lens is implanted into the bag, here we just need to pull out one flange, one of it comes out, and then the rest can be just pulled out. Even it comes out through even a 1 millimeter paracentesis, and the visco is aspirated after that, and the incisions are hydrated. So this is my case where we know that he is on tamsulosin, but then the pupil is around 6 millimeters to start off. Just after rexis itself, it has come down 0.5 millimeters, but then still I hold on. and then do a hydrodissection, very controlled hydrodissection, gentle, so that the lens doesn't tilt and lift up the iris. So now slow motion phaco is ready. Have only appropriate irrigation to have chamber maintenance and enough power to do your phaco for the particular type of nucleus. Here again, you can see I'm using a chopper which is a blunt tip chopper, 1.75 to 2 millimeters long, and I go to the equator and do a horizontal chop. I complete all the chops. So you can see that I am sweeping within the bag itself. I'm not withdrawing the chopper. So this is one way you can irritate the iris less. Each time you move the iris. Once the chopping is complete, I then take out the pieces. Chopping is done to make the pieces very small. We don't want the pieces to touch on the iris where it is coming out. And also, most of the times, your irrigation has to be over the iris. The irrigation going underneath the iris is the one which will irritate the iris and cause billowing, and then progressively iris prolapsing and the pupil coming down. And here again, if you notice, once the pieces are taken out, I am keeping the irrigation steady at one place itself, and then the pieces are now brought on to the tip with the fluid irrigation and the second instrument, and the emulsification is completed. See, people who are used to coaxial irrigation aspiration will have a little, see the pupil moving now. So this has started becoming floppy, and now this has happened, catching onto the iris. That is the ultimate thing which can happen. So I use the second instrument to retract. Here again, the irrigation aspiration, irrigation happens underneath. The bimanual irrigation aspiration is the best to use because the irrigation can be over the iris. But this can also be done, and I am trained in this, and I am very comfortable using this, and that's why in most cases I use this. I use the Kugelens hook or a Y hook to retract the iris at that point where you are planning to aspirate, and then underneath the IOL also one can aspirate. Now I stop irrigation and then withdraw. It is you come down to 0 and then come out. Still come out gently. If you come out fast, again you will get iris coming out. Rather than pushing the iris back, you can use the technique which was used before. Shallow the chamber and tap back the iris. So sometimes this is not a intraoperative complication, but sometimes when iris keeps coming out, you get frustrated. You push it along with your phaco probe, and you get iridodialysis. I just want to mention the technique of iridodialysis repair. If you get an iridodialysis, this is the swing method technique, which is very useful and very nice. So going 1 millimeter behind the limbus, this is the 27 gauge needle, and you thread the 10O proline through the needle. You thread it in, let it come out through the hub, and then put the plunger on, and then put viscoelastic underneath the iris and stretch the iris, and identify, make a paracentesis, use a micro rexis forceps and hold the iris, and then use the needle to pierce the iris through the root of the iris, take adequate iris tissue, and then come out through the groove which we have already made, and then pull out the free end. So one free end is out here, and then come back, and 1 clock hour later, next to the puncture which you have made, make multiple entries, and once this tip comes out, we can pull out the loop from the tip. So what happens is you get multiple loops here. You can make as many according to the number of clock hours available. So you will have one loop here, another loop here, multiple loops, and then cut the loop in the center. And then we have made one free end at this corner and another free end at this corner. So suture these adjacent ones and bury those knots into the groove which has been made here to do that. So that's a very easy and classic technique to suture the iris. And within the short time, I could cover only this much. There are a lot many things to say, I know. So during the discussion, let it all happen, and thank you very much.
Thanks a lot, Dr. Minu, for a wonderful set of videos and very good presentation. Would like to have comments from Dr. Ilan Kumaran, and then we will discuss.
Thank you, sir. It's a very good presentation by Dr. Minu, as usual, a very good teacher. He has made a mention of most of the things, including the predisposing factors and how to manage it. I'll just sum it up. Predisposing factors, you can probably classify them into preoperative and intraoperative. So there should be a high index of suspicion, particularly if this pupil does not dilate in the OPD. Any pupil that doesn't dilate in the OPD, always have a suspicion that this is going to happen. The second point, an intraoperative, he showed multiple causes. The second thing I would like to add, in case of slightest suspicion, he showed very beautifully in the initial days when we didn't have this pupil dilating rings. We used to try with the smaller pupils, try it out, then land in trouble, and then put an iris hook. But with the advent of cheaper pupillary dilator rings, it's very easy to insert it. At the slightest doubt, this should be available in the OT, and we should not hesitate to use that. Intraoperative causes, beautifully mentioned. One of the cause could be, definitely incision is the main cause. That is the one that leads to every other thing. But another thing, what I've noticed in the learning phase is keeping a high flow rate, high hydrodynamics inside the anterior chamber. So as soon as this happens, that should also be reduced. Probably lower the bottle height, reduce the flow rate, reduce the suction. And many times it doesn't happen with the main incision. We are very careful, particularly in the learning stages. The side port is the culprit many times. More so because many of the learners have a habit of pressing the posterior lip of the side port. So how to counter this? If it's a small enlargement, we can even hydrate the wound and then introduce the chopper again. This hydration itself will take care of to a certain extent. All of the points he has covered. Just one last point which I would like to add. In case of misdirection, aqueous misdirection syndrome, if it so happens, definitely it was a very beautiful management. But if it is a large one where we are not even able to enter the AC, previously what we used to do is go and do a core vitrectomy. That's what was taught. But now just putting in a trocar and cannula sometimes releases that fluid that has gone inside. And if that is not available, many of us are used to giving intravitreal injections. So we can just take any small syringe with 26 gauge or 27 gauge needle mounted on it without the plunger. Just go inside, it will release the fluid that is there and we can continue the surgery easily. These are probably the only points I would like to add to what Dr. Mino has already said.
Thank you, Dr. Ilan, for your wonderful inputs. We have some of the stalwarts sitting here in cataract surgery. Request Tityal sir first to, make his comments on this topic.
Nothing much to add because beautifully, shown and discussed the various aspects of iris coming into the wound area repeatedly. Both side port and main port has been discussed. And Minu has rightly pointed out your incision. That means when you make the incision, your keratome size and the things which are going to play inside, that is your tip and sleeve, has to be nicely co-opted to suit the flow you have chosen. That is very important part, especially for resident doctors, where sometimes they come and sit down with the same setup which the previous surgeon would be using, without realizing that your parameters and your incision, your blades are different. So that part they have to learn, and always they should make sure that they should check the machine themselves, set the parameters for their own, and see all the equipment, instruments, and especially tip and sleeve has to be checked because it may not be same as what you are used to. So that is one important point. Second, in a learning curve, sometimes, despite not having a floppy, you can create the floppiness of the entire pupil iris tissue by, catching the pupillary margin with your phaco or aspiration tips. So that should be nicely, should be avoided. Otherwise, your pupil will start constricting because of the release of the prostaglandins in these cases and create the things very, very difficult. As nicely pointed out, as soon as you realize your pupil is not suitable for a continuation of phaco, either easiest is the iris hooks, because you can customize the iris hooks as per your requirement. And in between the surgery, it is safer also iris hooks rather than going for the devices at this stage, because you can catch the rexis margin, you may have difficulty putting. The iris hooks are very simple and very comfortable for everybody in regards to finances and multiple uses also. Little bit on a femtosecond devices. Sometimes femtosecond application per se can cause pupillary constriction and floppiness. That has to be managed accordingly also. Many people like to make their manual incisions, which is also better place in terms of the head position, the eye orientation. You can place your incision in the right direction because your incision and your instrumentation has to be as comfortable to the incision. It should be as parallel. If you do an incision with a femtosecond, sometimes there may be a cyclotorsion when you are actually putting the incision, and your position can be very difficult to manage those cases. And the difficult orientation can also cause damage to the wound area, and leakage can happen in these cases. So those things should be considered. Apart from the increased pressure which can happen because of misdirection of flow, very rarely you can have a suprachoroidal hemorrhage happening in some cases, despite small incision surgery also. That should also be identified accurately. And these cases have a higher chances of post-op inflammation. So post-op, your treatment has been little modified as per the post-op inflammation in these cases, because most patients would have a systemic comorbidity if you have a floppy iris syndrome. So that should also be looked into. So maybe I can continue steroid slightly longer or anti-inflammatory for at least for 8 to 12 weeks in these cases, because CME chances would increase in these cases. Beautifully discussed and covered.
Thank you, sir. Some very good comments for you, Dr. Meenu. You have wonderful presentations, very nice presentations, wonderful videos. And there's a question also that you have shown iris hooks and these the rings in all these floppy iris. So most of the times you must be doing cataract surgery and topical anesthesia. So do you use any intracameral drug, or you put any subtenon block in order to prevent further pain and patient becoming uncooperative? So do you do anything for that? There's a question related to this.
Yeah. I use in all my topical cases, I use intracameral lignocaine, preservative-free 1% intracameral lignocaine in all cases. So with that, nobody gets pain if you use iris hook. There is a great feeling that if you touch iris, it will cause pain. Nothing, it doesn't pain. So hooks can be easily applied. Hooks, and even see at any point of time, if you feel that patient is telling something, or just supplement for 4 or 5 drops of intracameral xylocaine once more. That's all.
Okay. Any other comment before we move on to the next talk?
Rajesh, one point Ilan raised was, I don't know how many people practice, is that a outlet from pars plana, because we have been using this in phacomorphic glaucomas, shallow ACs, and a lot of disorders where pressure may be bothering for whatever reason. So although in a lot of my talks I say this technique of has to be learned by everybody. So any comment from the pioneers of phacoemulsification on this? Titial, starting with.
I really get jittery. I'm very afraid of touching anything beyond the limbus. So I don't practice that. If that situation of a misdirection comes up and high pressure, normally what I do, if I can place a suture, it's all right. Otherwise, I'll just try to hydrate the wound area, shift the patient to the recovery room, give mannitol, wait for another 40 minutes or so. By the time the eye becomes soft, and I retake the patient. That has been my practice for a few patients where I face this problem, because I'm really afraid of going past plana. So that
because I think Meenu's first video was on misdirection, and Ilan raised a pertinent point. So I thought because it is pars plana.
Yeah, newer generation people are they do it. Yeah. I've seen a lot of work from our glaucoma division also, where they do the pars plana. Even they do a little bit of a vitrectomy also in a phacomorphic glaucoma.
So let's hear from say Rajesh, Harbans, or
I have done it on a couple of occasions. Have you
regretted? Have you regretted? Or?
Yeah, Dr. Lalit, actually, if it is preoperative shallow chamber or phacomorphic glaucoma, I think we have forgotten the art of doing the massage and reducing the vitreous volume. When we used to do ECC, then we were taught doing the vitreous massage reduces the vitreous volume by 40%, while mannitol reduces only by 7%. So during ECC time and the vitreous space becomes concave and there will be no PCR in cases of ECC if you really do a good massage. So I think all these patients, those who have got a shallow chamber, if you reduce the vitreous volume, so the pressure from the top when you are doing phaco will be very comfortable. So I never needed to do the vitrectomy in these patients. I give a block and do the massage for 10 minutes and the actually chamber becomes reasonably deep for you to proceed further.
No, I agree. I'm not saying do a
So-
prophylactic kind of entry.
Yeah.
What I'm saying, I'm not in favor of doing a prophylactic entry.
Intraoperative, suddenly eye becomes very hard. In that case, it can be used.
I'll still go with Dr. Titial's philosophy. Make the patient wait for maybe, usually we have the long list 2, 3, 4 hours. And by that time, the pressure will come down in any case. And then you can proceed further. So there is no need.
What I would like to emphasize
the
is
case is in any case under topical. So putting one drop additional after 1 hour or 2 hours, only thing is that you've got to make the patient get up and drape clean again. But it is not, block has not been given patient under topical. So making him lie down again is not a big deal. So doing one more procedure, I think I'll rather prefer to wait for half an hour, 1 hour, 2 hours, and then proceed further. Unless it is the last case of the day and you want to leave.
no. What I wanted was that what I would emphasize. You see, learning is a continuous process. It's a medicine is interesting primarily because we learn every day from everybody. So what I was wanting to emphasize: no harm in coming out of this inertia or fear of entering into the pars plana. And actually, I have seen, believe me, a lot of eyes, and you see the pulse rate of the NTS7 surgeon coming down, sweat coming down, and not waiting for 40 minutes for this thing. And believe me, intraoperatively, if you're caught in a catch-22 situation, this sometimes may help. It is important that I think all NTS7 should come out of this cocoon of not entering the pars plana. So in any case, we should move on. Rajesh ka time zyada ja raha hai.
Yeah.
So I know Rajesh is.
So we move on to the next talk, and that is by Dr. Harshul Tuck, who will be talking about a situation wherein you get a torn rexis, the rexis is extending, and then you have to salvage the capsule, the rexis, as well as perform the procedure and get good outcome. Dr. Harshul Tuck.
Anyway, thanks, Elan, for pointing out this.
Thank you, sir. I learned it after one of your talks only, sir. Actually.
So let's hear Harshul Tuck.
Thank you so much at the outset, Dr. Rajesh sir, Dr. Tityal sir, and Dr. Namrata ma'am for your kind invitation. And so we all know that a perfect capsular rexis is prerequisite for a good phacoemulsification and a good outcome, and to put the IOL nicely centered in the capsular bag. But there are situations where we may not get the desired the rexis which we are looking for. So usually these are the cases which have. Can you see my screen, sir? Clearly?
Yeah.
Okay. So these are usually the cases like intumescent cataract, because there is a lot of liquefied cortical matter which is there and which increases the intracapsular pressure. As you can see in this case, is intumescent cataract, and a lot of fluid is there, which is raising the pressure. So this is the technique which I've been using for last 10, 12 years. This is a sequential 2-stage capsular rexis. So initially I go ahead and make a very small rexis in the center, and then I debulk the capsular bag with 27 gauge cannula. So you should go from the side port and debulk the capsular bag from one side. As you can see, as this cortical matter is coming up, the capsular bag is getting deflated. I go from the second side port. I go ahead and debulk from this side. Go from other side port also. So once you debulk the capsular bag, then you can give a snip with the micro scissors, and you can make a capsular rexis of adequate size. So this is a technique which works in almost all the cases of intumescent cataract or where the pressure is high, and you can safely do phacoemulsification. But there are situations like this. This again, the patient is under topical anesthesia. I'm debulking from one side, and I'm Now going from other side port, and just notice what happens as I'm debulking. Suddenly patient turns eye to one side, and you can see the rexis is trying to go southwards here. Again, see in the replay. Is there any noise coming, sir, in my audio?
No, it's
There is
okay. There's very little bit, very
Yeah.
little.
Okay,
Yeah,
perfect.
it's not disturbing.
So you can see again in the slow motion, I'm debulking and suddenly patient will move his eye and the rexis is trying to go in the periphery. So if you have a situation like this where it's not gone till the equator, so you can release this tension here by giving a cut with micro scissors. So straight away I go ahead and give a cut here, and this relaxes and takes off the pressure from this point, and I can complete this capsular rexis. So you should have these micro forceps and micro scissors in your armamentarium, which saves you. And again, give a cut here and complete this capsular rexis. So that saves the day. One more situation here, as you can see, the capsular rexis, I'm making this, but the moment I see that this direction of the rexis is going outwards, you should stop then and there itself and use the little quick pull technique or the capsular rexis salvaging technique you should use. Go ahead and put viscoelastic to unfold the flap, and then try to hold the flap from the root here as close as possible, and the direction of forceps should be centripetal towards the center. As I'm pulling the forceps towards center, the rexis is coming on the right track. So once you get this rexis on the right track, you can complete the capsular rexis. So you should have these micro forceps with you. Now have a look at this case. So when you become complacent, I was not using the 2-stage rexis here. I thought, but this cataract was very bulky, as you can make out. The anterior chamber was very shallow here. Look at this point. This is a weak point here, and capsular rexis is going outward. So if you have a situation like this, that you have a torn rexis here, which has gone in the periphery, and this case is again under topical anesthesia. So I go ahead and try to debulk whatever I can debulk with the 27 gauge cannula. And now our strategy is to maintain the closed chamber so that we don't extend whatever rexis has gone in the periphery, and so that to prevent the wraparound tear and to prevent the nucleus drop. So now here I go and complete the rexis from one side. And once you have completed from one side, go and give a cut here and trying to complete the rexis here. Again, going from side port, giving a cut on this side and completing the rexis. So in this way, we have almost complete capsular except this one place. Now coming to the whether you should do phaco or to ECC or SICS, whatever. I think it depends on the experience and skill of the surgeon, whatever you're comfortable with. So, but the thing is that some principle you need to follow is to maintain closed chamber technique. Never let your anterior chamber collapse. So whenever I prefer a direct chop technique, because that puts the least stress on the capsular bag whenever you have situation like this. Don't do much of the lateral separation of the nucleus. I don't do hydrodissection in this situation. And once you've divided the nucleus into smaller pieces, so you can easily take them off one by one, like piece of cake. And this is the last piece, which I'm taking out. And you can see the, so again, before withdrawing your phaco probe, you need to put viscoelastic to maintain the closed chamber. So I go ahead and viscoelastic before withdrawing phaco probe, and then do the bimanual irrigation aspiration. So always try to take cortical matter from the area where tear is not there, and then come to the area where you have a tear. Again, before exchanging your irrigation aspiration cannula, put OVD and come out, and then you change your cannulas, and this is the area where tear is there. I'm taking out cortical matter. So once you complete irrigation aspiration, again put OVD, enlarge the incision. And coming to IOL implantation, you should not try to rotate the IOL and put it in the capsular bag. So once this leading haptic is go, you just bend the shoulder of the haptic here and just push it in the capsular bag so that you don't extend this tear and the area which is weak there. And you have a IOL which is nicely sitting in the capsular bag. Though here the overlap of the optic is too much, so I again go ahead and enlarge this capsular rexis so that we have good overlap all around, and this finishes the case. And even before coming out and taking out OVD, I'm hydro stitching all my incisions, main port and side port, before I withdraw the irrigation cannula. So the idea is not to let anterior chamber collapse. Again, same situation here. Now coming to the situation where you may have a torn capsule in the case of traumatic cataract. So this is a traumatic cataract. The case had a history of trauma. So you're not sure where the capsular rexis margins are. So in situation like this, before staining, it's always good to take off some of the cortical matter and then put dye there. And once you have stained the anterior capsule, you can see the margins of the capsule. As you can see, there's a soft fluffy cortical matter. So there's a word almost tear from one end to the other end. But you can take off all the cortex, put IOL in the capsular bag. Because this is a very small opening here, so before putting the IOL, here again I'm doing visco exchange, put viscoelastic before coming out, and then enlarging this from one side so that I can put an IOL in the capsular bag. Again, the leading haptic goes and I just bend the haptic to push it in the capsular bag. It finishes the case. So I think with this, I finish my presentation. Thank you very much for giving me this wonderful opportunity.
Thank you, Dr. Harshul, for very, very nice videos, and some of the videos wherein you had to use viscoelastic apart from the hydro that you always use. And,
yeah.
So would like to have comments from Dr. Rajesh Joshi on this condition.
Yeah, nicely covered, Dr. Harshul. Losing a capsular rexis is like losing a battle before you fight it out. Harshul, as usual, it was master stroke by master. I think 2-3 points which are important are recognition beforehand when it's going to extend, isn't it? So shallow chamber and the intumescent cataract, these are the most important conditions in which there are likely chances of extension of capsular rexis. I liked your 2-stage rexis, but I tell you what I do. If I find such type of cataract, I make a small, very small incision, like 20 gauge incision, and introduce a 26 gauge needle after putting viscoelastic, like maybe like soft shell technique, initial hydroxymethyl propylcellulose and then sodium hyaluronate, so that the chamber is formed well, and just debulk the nucleus, and then go ahead with micro scissors or micro vitreoretinal forceps for completing the rexis. Use of trypan blue. In fact, in each and every case, I use trypan blue, whether it's immature or mature cataract, because that comes handy identifying the extension of the tear while performing rexis as well as while performing phacoemulsification. Because sometimes it happens that your chopper may cross over the rexis and may tear the capsular rexis margin. So recognition becomes difficult if you don't use trypan blue. So trypan blue has to be used in each and every case, not only the white cataract, but as well as immature cataract or nearly mature cataract. Of course, size, you cannot control size whenever you have an extension of rexis, but it's always better to make a small size and then extend later on once you are done with the phacoemulsification. Then some capsules, I think, whatever you do, they are destined to extend. I don't know the reason. You need to find out what is the elasticity, whether the trypan blue changes the elasticity or what happens, I don't know. But some capsule, whatever you try to do, it's going to extend. So it's difficult to control such capsules. And apart from that, one thing I want to mention, if you have an extended rexis and you are going with the phacoemulsification, you need to find out the flutter sign, which has been demonstrated by Dr. Rohit Om Prakash. I think if you find that it's not fluttering or fluttering has stopped, it seems that there may be some vitreous in the vitreous trying to bulge through the zonules. So that is an important thing which you need to identify. Overall, very well covered, Harshul. And I think,
Thank you.
Yeah.
Thank you, Dr. Joshi. Yeah, Rajiv wants to say something.
Indeed, Harshul, it was an excellent presentation and great
you.
comments by Dr. Joshi. I would just like to know, Harshul, what's your perception about once you have had a tear extending, capsular rexis tear extending towards the equator, and we really don't know where we are. What's your opinion about prolapsing the nucleus into the anterior chamber and doing a supracap phaco? Is that an option, viable option?
See, I think I never do that, because what I feel is that, most of the time, you're close. If you maintain a closed chamber, that helps you most in these situations. For years, I've done a lot of cases which had, the tear extending in between. We keep on getting cases like this, but none of the case had wraparound tear, because first we maintain closed chamber technique. That is most important thing. The moment you come out, the anterior chamber, it collapses like this and everything gets pushed up, and your, the anterior capsule tear, it wraps around like this. First thing is that. Second is your chopping technique. I feel that if you do direct chop, that puts least pressure on the capsular bag, because you're not trenching, you're not pushing the nucleus towards equator, and you're not, so now the situation is that whatever is there, you need to be gentle on intraocular tissues. That's what helps most of the time,
So
and it saves you.
What about the
It saves you.
supracapsular technique? That's what I wanted to know.
See, that also, when you try to take out from the torn capsule margin, it may extend it. So I never prolapse it out and do. Moreover, it's very difficult to do supracapsular phaco, in my opinion. It's very difficult to save endothelium and to chop nucleus. So most of the time, for years, I never had even a single case which had, wraparound tear. And Dr. Rajesh, I'll show you one more video there in which I did hydroimplantation also. So if you are confident, if you maintain closed chamber, you can do it. Yes.
I think, Rajiv, what Harshul is saying makes sense, because the rexis will not extend posteriorly if the pressure is from the top. It will only extend posteriorly when there is a pressure from the behind and everything tends to prolapse. So if you maintain the pressure from the top, it will never go. So there should be no attempt to do supracapsular phacoemulsification in these cases. Second, you need to differentiate rexis margin tear into one is the curvilinear and as the conal. Like in a younger patient, when you make and extends peripherally, which is in a curved shape, it will not get extended. So don't worry about them. But it is which is the cone and cuts in an intumescent cataract, that has got more chances. But if you maintain the pressure from the top, you don't have to lower the parameters. You don't have to lower the bottle height. Nothing, just maintain good pressure from the top and it will keep the posterior capsule behind.
And one more thing about the flutter sign, no flap motility sign, but the Dr. Joshi was also mentioning. What I felt is if you have a bulky cataract like this and this your tear has gone in periphery, that time flap won't flutter. It won't move also. So you won't be able to differentiate whether it's the going to be wraparound or what is it. It's only once you're taken off the nucleus and there is a space in the capsular bag, then it starts fluttering. So then it becomes too late. Yeah. So when tear has gone, there is only one way which I feel you need to proceed is to maintain closed chamber and take your chances. That's it.
Yeah, I mean.
Yeah, very good presentation, Dr. Harshal. I would like to know your opinion about implanting a single piece multifocal IOL when you had extension of the rexis. And in which situation would you change your plan of implanting that IOL?
Yes. So there have been situations where we needed to, we had to defer the putting trifocal or multifocal IOL in patients which had intumescent cataract, and we had the torn rexis. So straight away we told patient that no, this is not a good option for you. So I will never say that one can implant a multifocal or trifocal. Toric is fine. Toric is fine, but multifocal, trifocal, never.
But
because it needs good centering, because it needs good centration, and it should not be put.
Go ahead and put, if I already committed to the patient of putting multifocal, if there is no PCR, if there is only rexis margin tear, I'll still go and put ahead with the multifocal. And because these lenses, hydrophobic lenses, are very sticky to the posterior capsule. So once you put it and center on the table, the chances of decentrations are much less. Particularly if your rexis is not very small, if there is not a very dense fibrosis is going to take place. If the rest of the rexis is large enough not to have a ununiform pressure from different sides, that means one side capsule is a lot, another side is cut, then it will have a lot of pressure from that side. But if the rexis is large, if you put a lens over there and press with the air of the posterior capsule, and there is always, whenever we do multifocal, if patient is not happy, there is always option that we replace with the monofocal anytime. So that we do always free of cost to any unhappy patient of the multifocal. The laser and the exchange of IOL is included into the package.
Rajesh, Sirana, I am utterly confused because one doin says not put multifocal, another says put multifocal. So let the final word come from Tityal. because what I'm saying is because some clear messages should go from this important webinar, because you have made so many efforts. Because you see, because Harshul is very clear, I will not put. Harban says I will put because I have committed. So Tityal, what do you say?
So what would you do, sir?
There are situations, and it depends on what type of rexis tear you have, which particular axis you have, and what was the other eye situation. If other eye has a cataract, then
other eye has multifocal. Other eye has multifocal.
So we have an easy way of counseling the patient. We'll shift to the monofocal. Patient might agree, but sometimes we do have a patient who has a trifocal in the other eye, and this eye has a torn rexis. Then in that situation, I'll go with the doctor. Harvan, put the lens. If it is going to cover almost not 360 degrees, actually 340, 350 degrees. And haptics should be oriented in such a manner it may not get engulfed into the tear area, because tear area is going to fibrose and get attached to the posterior capsule much sooner than the area which is being covered by the rexis on the IOL surface. So that has to be avoided. And maybe, as Dr. Harman rightly said, if there's a little bit of a decentration might happen with the fibrosis happening in the post-op period, these patients require a regular checkup. We can just do a relaxing, incision by the YAG laser onto the capsular rim, and that will prevent the shift of the lens. As far as toric is concerned, if my toric axis is happening onto the tear area, then it's very difficult to hold the lens at that position. So that is going to be a little challenging. But as Harshul nicely talked about, in toric also, if you can maintain the chamber pressure, the lens can settle down in that axis also very easily. But yes, there will be a little chance of decentration of post-op period. Otherwise, any situation in posterior capsule is intact, I'll pull the lens in that patient because it will not going to really create the problem. But if a rexis is too large, despite having a tear, it's not going to hold the remaining area. The anterior capsule doesn't overlap onto the IOL surface. Then it's going to be a difficult situation. In that situation, maybe you shift to the monofocal, or maybe I'll go to the other extreme to put a 3-piece lens, the sulcus, and make a capture in that situation. So it all depends what type of situation we have. But most likely, 99% cases, we can put the lens easily in these cases.
Great, great.
If we have a good anterior capsular wrapping over the capsule, we align the haptic in a proper position, we can put a multifocal lens. The issue is about toric lens if the tear is in the axis of the IOL. There's this was one question which I had thought of putting, that what will you all do if there's a tear in the axis of the toric lens?
Yeah, that is a challenging situation. But you know that these open loop haptic lenses would be a little challenging. But if you have plate haptic lenses, they settle down very nicely. Yes. Even you have a tear also. In that situation, you might opt for those lenses.
Yeah, I think we can move on because time is not on your side.
Only thing is a toric IOL, in any case, you can always do laser afterwards to correct this lenticle power. So not so much of an issue. But having a multifocal in one eye and the other eye putting monofocal will be a bigger issue.
Yeah. I think more challenging is what the posterior capsular tear is going to cover. And you have a trifocal lens and patient is that is going to be challenging.
Arbaish sir, maybe put a monofocal IOL and later on you can put a multifocal sulcoflex.
Yeah, that is also true.
When lens settles down nicely. Monofocal.
I got no experience of multifocal sulcoflex, and that is a refractive type of a lens, and which has been criticized a lot. So I really don't know what is the quality of vision with that.
No, but I totally agree with you, sir, that if other eye has a trifocal or multifocal, of course you can put. I don't deny that.
Ashul, I have seen a lot of patients who had a young patient with the PCR, with the multifocal decentered. He was quite comfortable, computer professional. So I think that phobia also has to go out of mind that all patients who have 0.5 millimeter decentration are going to be unhappy. So of course there are more chances of their being unhappy. So, but we should not really so much bothered about and keep on worrying about it. Otherwise, we don't measure so many times. We don't look into what is the angle, how it's going to decentration. So many of the optics are half covered with the people, half not covered, but these patients are doing very well. So there should not be so much of an apprehension about putting multifocal IOLs.
There's a question for you, Dr. Harshul, and that is which cannula you use to aspirate the cortex if you make a small rexis before you...
That's a 27 gauge cannula, which comes with the viscoat and all those, viscoelastic. So it's it has a very small bore and it easily goes through this very small rexis. So the trick here is to make a very small rexis possible, 1.52 millimeter in the center, That is the safest area central where you can easily make it. The mid-peripheral area is very dangerous where a lot of cortical fluid is there.
True. There's a bend there. Yeah, Dr. Rajesh, you wanted to say something.
Yeah. What about the extended depth of focus? Suppose if you have extended rexis and other eyes having multifocal.
Same as multifocal.
I think that is still more forgiving than a multifocal. So one can put.
Yeah. Just a final word on our intermittent wide cataract. I think it is important to do a good examination as we have described the various types of intermittent wide cataract. If you do a good slit lamp examination or anti-segment OCT, if you have, you can classify your cataract, which can be amenable to aspiration by needle. Many people do that. Which type of cases you may not achieve with the needle aspiration, where you have to do a bimanual aspiration, as Harshul was talking about, or which are those cases where you have a totally fluid or partial fluid, where just a needle puncture will release all the type of milk. And there's a wide cataract where you don't have to do anything with it. Normally act like a normal cataract also. So examination is very important aspect pre-op, because many people will not have an intra-op OCT like we have. So if you have a white cat, you should classify before you give a date for surgery. Okay, type 1, type 2, type 3, according to your own judgment. And that will give you access of managing. Like we talked about giving mannitol to these patients, shallow antechamber, giving block to these patients. And then we can decide, should I do a needle aspiration or should I do a small opening, then do a bimanual aspiration? Because the cortex is hydrated, there's no fluid. So that will not come with a needle aspiration. There you have to do a bimanual aspiration. I think if they do that, the chances of extension to periphery will be less, though it can still happen. Because so many things happen intraoperatively, which normal case also, beautiful cataract, you can have extension there also.
Thank you, sir.
Okay. Actually, Jepto and
So-
Hertel really are very good for these cases.
Yeah.
Yep.
So we move on to the next talk, and that is by Dr. Harbansh Lal, and he'll be talking about one of the dreaded complications that we keep talking about, and that is posterior capsular tear. So
I'm
how will
sorry,
you
Rajesh.
manage?
I'm sorry, Rajesh. ये question मैंने उठाया to raise this controversy because I thought clarification is required.
Yeah, absolutely, sir. Absolutely.
Because the audience should have a clear cut this.
Yeah.
So thanks to Tityal and all these people for clarifying everything. Yes, Harbansh.
You can see my screen.
Yes,
Yeah.
sir.
So first, if PCR happens, do not remove the probe abruptly. If you remove, the chamber will collapse and vitreous and highlight phase will be broken and vitreous will come to the anterior chamber. So before removing the probe, put on a viscoelastic from the side port so that the vitreous is pushed back and you can proceed further. So I'll just show you a small video of what to do and what not to do. Now, if you look into this case, this was a hard mature cataract. And when we are into the last fragment removal, the side port wound is much bigger and leaking profusely. There is a sharp chopper in hand which is pointing backwards. And there is a Kelman tip which is bent backward, and the vacuum settings are 600, which I normally keep in a hard and a mature cataract whenever the cataract is hard. So suddenly, I'm showing you in a slow motion, and this look at what happens. The capsule is caught and the PCR happens. So whenever, now of course we go and put on a viscoelastic before we're drying. And so that the vitreous is pushed back. Then most of the time vitreous will have a tendency to come towards the side of an incision. That means PCR is here, it will come on this side or this side if it is come to the AC. So I'm making another side port here, another side port here, so that I do not go in the direction where the vitreous might have moved, if at all it has gone on that side. And I want to make sure that I am able to remove the epinuclear plate. I think we have dropped more epinuclear plate into the vitreous cavity than nucleus, because it is very difficult to hold on to the epinuclear plate. Now I'm relaxed and I'm using, you can use the vitrectomy cutter, which can be interchanged into the IA mode and a cut mode if any time you feel the vitreous is coming. So once whole of the cortex is removed, then of course the rexis was a little smaller. We enlarge the rexis as already shown. And then instead of putting a single piece lens, you can go and put 3-piece lens. And you can put this sensor type of lens into the sulcus without any problem. So this is put underneath the iris. Of course, this is just possible to put this lens into the capsular bag, but we are putting the sensor lens, little comes out in a jerky fashion and the loop rotates a lot. So there are more chances of PCR as compared to the other lenses.
There's some sound coming at the back, I think.
I really don't know from where this sound is coming.
Yeah, that's what I was saying.
Same thing was there, yeah, coming.
So this is another patient now. This is same type of a cataract. We use the long and sharp chopper initially to divide, but only difference was that we removed the sharp chopper before removal of the last fragment and lowered the parameters of the vacuum to around 400 or so. Now there is no leakage. chamber is maintained better, and you can even put the Kelman tip facing sideways. So this is very important if you feel the necessity, because these big nucleus makes the posterior capsule lax actually, and most of these patients may have jugular laxity also. So you can put on a viscoelastic in these patients if you feel the necessity, but just removing the chopper from the side port and reducing the vacuum setting will help you in preventing the PCR. So last fragment removal is very, very tricky. And as Harshul, I also prefer to do the hydroimplantation in these patients. So to have a low PCR, bottle height should not be kept more than 100 centimeter, because it only increases the intraocular pressure, and slightest fluid withdrawal will cause much more fluctuation. So the bottle height should be vacuum settings, low versus high. You need to find a balance, because low keeping vacuum settings will make it very, very uncomfortable, painfully slow procedure. High, very high settings will make it very efficient, very fast, but they'll increase the risk. Chopper, initially you can use this sharp and long, but then ultimately when you come to the last fragment, take a smaller chopper. Side port incision is very, very crucial, and make sure it is not leaking, because we do bimanual aspiration and try to make a side port equivalent to the size of the cannula, while the chopper is much thinner. In a tougher situation, you can make initially a small side port. CCC should be adequate. If CCC is very small, then you may have a problem. And even if it is very large, the nucleus fragment will prolapse into the interior chamber. You should make sure that you are able to rotate the nucleus. Do not hesitate to use the pupil expander if needed. If you are doing a stop and chop, make sure that the trench is adequate. Actually, the biggest problem is when the trenching is not good and the cataract is very hard. And when you are doing last fragment removal, I already shown. But if it still happens, avoid falling of the nucleus, epinucleus posteriorly, and the corneal damage. These are the two main goals. Of course, there are secondary goals: prevent enlargement of the tear, prevent damage to the CCC, minimize the size of the vitrectomy, avoid traction. There should be minimal leftover cortex. Wound size should not be enlarged much, and IOL you should be able to center. So nuclear fragments, when we remove, I'll describe one chopstick technique, vitrectomy, how to move the epinucleus, cortical matter, and IOL. So wide phaco presence of the vitreous, that is very, very important. If you are not so sure whether the vitreous is there or not, you can do the limited vitrectomy or use the chopstick technique. The chopstick technique, you can use any two instruments to remove manually the nuclear fragments from the eye. So these two instruments have got an advantage that you can make a very small port from anywhere you can enter, even from the pars plana or from the limbus or from the cornea. And this can be used to relocation of the intraocular relocation. That means if the nucleus is in the capsular fornices, you can pull it out and place it in front of the iris. Particularly if there is a nucleus fragment which is on the temporal side, subincisional, it is very, very difficult and very risky to rotate it. So you can make an incision to the other side and can pull it out from the capsular fornices. And once it is out in front of the iris, you can take it out from the incision also. So this is one of the small clips. So you can see that there is a small fragment which is lying in the capsular fornices. One is the chopper and another is the dumbbell dialer. Just you can pull it out and place it in front of the iris so that you have got a peace of mind that it won't go behind. Pupil is also a little on the smaller side. Now you can put on a viscoat, and then you can go and proceed with the phacoemulsification. And if you want to remove it manually with the same technique, you can enlarge the incision slightly, and making incision of 4 millimeter size or so is really not a big issue if you have got to choose between pulling on the vitreous and enlarging the little bit of incision. So enlargement of the incision is far more safer than doing it. So this way you can, and now this whole thing is hypovolumic. That means your bottle height is around 60 centimeter. Vacuum settings have to be low, flow rate have to be more, and maybe you can use more of the phaco energy in such a situation. And we put on a viscoelastic before drying the infusion cannula. So the chamber depth has to be maintained throughout the procedure whenever you have got a PCR. In any case, in all the cataract surgery, chamber depth has to be maintained. I maintain the chamber depth always in all cataract surgeries, whether there is a PCR, rexis margin tear or not. So this is another video. Same thing can be done if there is a large fragment which is there, enlarge incision to 5.25, and then you can really pull it out with the two instruments very easily. One is the chopper, and you can have two choppers. So the long axis of the fragment is perpendicular to the long axis of the incision. So this way you can remove the hardest of the cataract, but this technique will not work if the cataract is soft or it will cheese wire through. So you can use the combination technique. Now the IOL scaffold is very popular, but IOL scaffold works very well only in cases of the mature cataract where there is a very little epinucleus or the cortex is left, because then that procedure becomes a little difficult to do. So you can see there is a PCR which gets enlarged when we try to put on a viscoelastic, which was small to start with, but when we try to lift this fragment, it is getting enlarged, and we over-injected the viscoelastic, it enlarges further. You can see that it has extended full. So, but still this fragment is lying here, and before we can proceed any further, we have got to take it out of the capsular fornices. Only then we will like to do the IOL scaffold. And once it is taken out of the capsular rexis margin, we can enlarge the incision, make sure that it is out. This is really reasonably firm cataract, and I thought I can take it out with around 3.5 to 4 millimeter incision. So we enlarge the incision. This is 2.75 knife. Initially it was 2.2 incision to start with. This is 2.75 and last to a little more. So then we try to remove it. Some of it comes out and we are not able to in toto remove it. And then we put on an IOL in front of the iris, and then we place it underneath the iris on top of the capsule. Once the lens is in position, now if you are not so sure whether the vitreous is there in the AC or not, you can again manually remove this cataract. So we position it and again go and pull it out. And once it comes out, then you can use the vitrectomy cutter, as in this case. So remove all the blood from there, which was there. And if by any chance you feel the vitreous is in the AC, you can go ahead and remove that also. So the advantage of chopstick technique is that instruments are very fine, maximum maneuverability. Pieces you can remove through a smaller incision. If you use the wire vectors, should never be used, because you take the counter pressure either from the cornea or you press the posterior lip, which will prolapse the vitreous. And there is no hydration of the vitreous in this case. For anterior vitrectomy, everybody should, be well accustomed. Your staff, everybody should be well trained how to use it. So it is very important to have a dry run. And high cut rate should be used for the vitreous and a low cut rate for lenticular matter. And settings will depend upon the type of the tip you have, whether it's 23 gauge, 25 gauge, or 27 gauge. So when the secondary IOL implantation is always an option. So as in this case, the resident was operating, you can see that there is a last year, the pupil is dilated. So we separate the iris from the capsule and put on a viscoelastic between the iris and a capsule, because this is where you want to have a gap. So do not hesitate to put on a large IOL if you are not sure about this capsular support which is available. So there is not much of a rotation. We put the lens, and I always prefer to do the vitrectomy after constricting the pupil, because in this case the tricot will not go back and you will remove all the vitreous. So this is again this same thing that I always prefer. I do not prefer to put the tricot beforehand because it may go into the vitreous cavity. So put the IOL, constrict the pupil, and then do the final vitrectomy. You always find some fibrils. And the ideal is, these are the old videos. Ideal is, do not hesitate to go to the pars plana and do the vitrectomy. There will be nothing will be there. So to conclude, do not allow the chamber to collapse. Chopstick technique can be used for the nuclear fragment removal. And anterior vitrectomy should be done final vitrectomy after IOL implantation, even if you have done the vitrectomy before, and if you feel, because there may be still some tax there, consider the people use the tricot. Secondary management is always an option. So do not hesitate if you've got any problems, you are not so sure. So I have postponed sometimes cases where the things are not gone well, and come back after 2 weeks, 3 weeks, 4 weeks. There is nothing wrong in doing that. And do not damage iris capsule cornea. Rather, now, because the posterior segment surgeons are now really doing excellent job. So if you really feel very uncomfortable doing and trying to pull it out and damage everything around cornea and iris and a capsule, so it's better to drop the nucleus into the vitreous cavity, put the IOL, keep the cornea clear, and take your VR surgeon friend, Dr. Lalit Verma. They'll be very happily, they'll be able to remove the nucleus from the posterior root. So instead of damaging everything into the anterior segment where the iris is becoming floppy, capsule is torn, cornea is gone, big incision is made, you're putting sutures. So it's better to drop the nucleus and call your VR surgeon friend. Thank you very much, Rajesh, Dr. Professor Tityal and Dr. Sharma for giving me this opportunity.
Thank you, sir, for an excellent presentation. It was really very, very, I would say, informative and very practical and very useful. Would like to have comments from Dr. Amey Kulkarni.
Yeah. Thank you, Dr. Harbans Lal, sir, for a very comprehensive and exhaustive presentation on PCR. I'm not sure what I can add to this. There are certain points, I'll just summarize some points for our audience. There are certain things that we need to be mindful of while we're dealing with PCR. PCR is reality of life, no matter whether you're the resident learning surgery or you're a doyen, like those are sitting here, everybody has PCR. So identification of PCR, I feel, is the crux of the matter, wherein you can have direct identification where you see the PCR happening, or there are certain indirect signs. Like there might be sudden deepening of the AC, there might be a pupillary snap, there might be sudden brightening of the fundal glow, or there could be reduction in the fallibility of your pieces. But the one thing that I have found is the gut instinct that every anterior segment surgeon has, that something has gone wrong. Now I believe there is a Murphy's law in ophthalmology that if you feel that there is a PCR, stop, because there is a PCR. That is what I feel. So we need to stop when you feel something has gone wrong. As sir said, the first and foremost is to breathe in, breathe out, let your pulse rate go down. Do not take out the instruments from the AC. And one important thing that we need to make sure while we ensure a closed chamber technique here is the use of dispersive viscoelastic initially itself. That in itself will reduce the chances of the vitreous coming up. And once we do that, I think PCR management in itself is a study in what not to do. So basically, we do not let the AC collapse. As far as possible, we do not let anything, we do not leave anything in the AC, not the vitreous, not any fragments of the nucleus or anything else. And the most important point is not to go fishing in the vitreous. No matter how small you think the piece that is sinking, how close it is to your PC, please do not go fishing in the vitreous. Another point, as sir said, after everything that you have done, please put in a tricot stain. You might not see anything there. You might feel it is all clean, but please stain at the end and then make sure that there is no vitreous strand there. And this is my personal opinion, sir. You might differ with it, but I do believe that no matter what experience you have, I've seen surgeons who claim that they do not disturb the anti-hyaloid face, which I believe is very, very rare. If you've had a PCR, it is always safe to assume that you have disturbed the face and take steps accordingly, rather than pray that you have not disturbed the anterior hyaloid face. So that's it, sir. Thank you for a very good presentation.
Thank you, Dr. May. There's a question also for Dr. Lal, that how to prevent nucleus drop, and I guess you have summarized it very well. That the first point that you said, that you have to have the highest degree of suspicion. The moment you feel that there's something wrong, you stop there before it's too late, before the nucleus drops, and the case goes to Dr. Lalit Verma. No, sir, Dr. Bansla?
Yeah, I think that's perfectly all right. I mean, if you feel that you will mess up, it's better to cool down and
Send
do
it to,
yeah,
send
delay
it
it
to
actually.
Lalit sir.
That's-
No, one point can I
Yeah,
make?
please, Dr.
See,
Meena.
once we
Yeah.
have a PCR and we are sure, it is better to let go HPMC. So when you have HPMC all the while, it is better to leave HPMC, use dispersive viscot. I have no financial interest in that, but viscot and even Indian companies also make similar combinations. So viscot would be the best to use. And once you finish vitrectomy and then you want to place the IOL, then a cohesive viscoelastic will be very good so that it can be aspirated off very easily. And also when we have the possibility of a rigid IOL to be placed, because of whatever reason, I would just, if I have not extended the main incision, I would not extend it further and make a sclerocorneal incision in another location and insert the IOL and close.
Yeah. Any other comment? So
Now
yeah,
coming back to the question, sir. What about role of trifocal, multifocal with other eye having the same thing, sir?
In a
Other eye
PCR.
having in a PCR. One eye has trifocal lens, we land up in a PCR.
Rexis has gone beyond being extended, and there is a big, large PCR.
See, the again, there is a PCR only, and there is not so much of a vitrectomy done. I mean, that means if you feel rest of the things are perfectly all right, like there are many times you will have a PCR, but vitreous not coming into the AC. So in those cases, there is no problem in putting the multifocal IOLs. And but if there is a vitreous has come and which is very little, I mean, very small vitreous, which you can feel has been cleared well, because most of the time these patients will not be having very hard mature cataract. The one who has already one eye multifocal and then comes for the second eye may not be that bad. So if it is a really bad case, hard cataract, floppy iris, you're not very sure about the outcome, then I won't put it. Even if it has got a multifocal IOL in the other eye, I'd rather not put IOL at all and take up the patient after 2 weeks. And then because that time, after 2 to 3 weeks, the capsule gets formed up. As after fibrosis, it becomes strong and hard. So even if there's a PCR, you do like vitreous is prolapsing, you can do the vitrectomy and put the lens into the bag after 3 weeks very comfortably, because the entire capsule can be separated. But if there's a large PCR, you're not so sure how it is going to happen, I will not put it. I do not hesitate in postponing the patient for 3 weeks, because then the capsule really forms up very well, 3 to 4 weeks. Then you can put the IOL into the bag or into the sulcus very comfortably.
So I guess if you can put the IOL in the bag, you can still go ahead and put the multifocal lens. And if you can't put in the bag, then monofocal.
No, if the eye is otherwise good, I mean, not very hard cataract, not very messy surgery, but if you feel the cataract was really tough and everything was really very taxing, you took half an hour to really handle all those things, then I think it's not the right thing to put it over there. I mean, everything went smooth, just by chance at the end of the stage you had PCR and not much of the issue. Go ahead and put it.
Okay. So we move on to the next talk, and that is another dreaded complication, and that is a sequelae of what has been presented, and that is nucleus drop, wherein we require a VR surgeon, and we have Lalit Verma, who is an excellent VR surgeon, who will be talking about nucleus drop.
So I hope the screen is visible, Rajesh.
Yes, sir.
So thanks to this great society doing wonderful work, SCARIS, GST, Namrata, and 3Rs, Rajesh, Rishi, Rajiv, who are doing these webinars, I think every Friday, if I'm not mistaken, and taking up very, very common topics. And today, this comprehensive cataract surgery, very few people talk about it. People talk about every day. You see about cataract surgery and a lot of videos being shown. But complications is of late not being spoken to, and hence the relevance of this. So I will just begin from where Dr. Hermans left. PCR, because a lot of times PCR may be accompanied with nucleus drop, it may not be. I liked a couple of comments from Dr. Amaya that PCR is a reality. And second comment he made was not to go fishing. And 2 comments by Dr. Hermans, again I noted down. One was anterior vitrectomy should be learned at all. And secondly, VR surgeon is your good friend. That again was a commendable thing. So let's begin with, you see, phaco, everybody has to learn today. And the only challenge is that, the beginners may be afraid primarily because of PCR and sometimes nucleus dropping. And as Dr. Maya was saying, it is even the experienced phaco surgeon may still get it primarily because of, besides other issues which were pointed out, is sometimes overconfidence also. So I'll just, Rajesh had told me do's and don'ts, what should be done for cataract surgeons. So always don'ts come to my mind first. Do's, because do's are generally domain of or maybe VR surgeons. So don'ts, which I think have been touched upon also, and Dr. Harbans and Amaya both have emphasized. So two things want to re-emphasize. Don't go after the nucleus at all, because I don't believe this concept of small vitreous and big vitreous. Any vitreous disturbance, long-term, lifelong, problem with that eye, CME, contrast not good. He'll start comparing. Doctor Sahab, ye aankh us jaisi nahi hai, jaise wo dusri wali. So believe me, any vitreous disturbance is bad for the eye. And if you may not feel at that time because you have done your job, but post-operatively, these patients are not the same as the other eye. So don't go after the nucleus. Avoid all this big instrument going inside the eye, like vectis or loops going inside the eye. And I would definitely advocate avoid limbal retrieval, because generally not only it is futile, but it causes a lot of issues which have repercussions like corneal edema or distortion, folds, suboptimal view, and further makes the subsequent surgery by the VR surgeon difficult. So these two things I think are the hallmark for as far as don'ts are concerned. So all of us keep shouting in all the webinars, but still, believe me, a lot of people do not pay heed, because it is the ego at that time, because I have promised this, I have to put the lens. But I'm very happy Dr. Harbans thrice he has said he may postpone the surgery in the good interest of the patient. So this is one small clip showing this disaster has happened and this nucleus is here, and see what is being done. You see nucleus and vitreous are admixed, and you see this movement which is like jhadu here. You see vitreous is disturbed for lifelong, and believe me, this patient is very likely to end up in a lot of posterior issues, which may include giant tear also if you push the vitreous like this. And further, what is being done? You see, if you try to grasp this nucleus piece with a forceps, which is admixed with the vitreous, it will not. You will keep pulling the vitreous also. So pull of the vitreous is dangerous. So this maneuver should be avoided at all costs, primarily because there is solid vitreous, gel kind of vitreous, which you are pulling once you are trying to pull this fragment. So this should be avoided. If you are acting in the interest of the patient, if you want future retinal complications to be low, if you want CME not to be there, tears, giant tear, all these maneuvers are deadly, dangerous, very dangerous. So this, I will tell you one story, because this we had, by chance got videographed, because this was a cataract vision pre-operatively, 6x9, 6x6 parts, and all the cataract surgeons, the moment they see small opacity also, they go inside and operate. So this was, you see this video, I'll try to cut it short. We'll start from here. So we keep saying about all this is do's and don'ts for these cataract surgeons. So this was the pre-operative. Now you see surgery has started. The initial steps have been done. Rexis on all have been done. Looks like a... Notice this movement of the iris, in case you have noticed. You see there is already some issue. You see what is happening. You see iris is being withdrawn. That means there is something wrong in this eye. So now the surgeon starts panicking. He is inserting various instruments now, putting some visco inside, because already there is some disturbance, as is, you see again iris Now he's thinking of putting some endocapsular ring to stabilize. Then he decides against it. Then put this ring aside, does not put it inside. Enlarges the incision because patient has been promised a phaco. Now this phaco incision has become like ECC. Definitive steps are not being taken to close the wound or suture it, but continue with the surgery and enlarge this. And then this ghastly instrument comes in, rexis, which I think has been emphasized by everybody, not to put inside. In a double mind, again, aim is, you see, put the ego at a standby mode. Now, this is again a disastrous movement. You see in the presence of PCR, trying to rotate this nucleus, which again is contraindicated. So these are things which are not to be done. You see what is happening now in the upper part. You see this globe is folding here. So I want to emphasize what should not be done. Again, some visco as if to push the nucleus further down. So again, indecisive moments in the cataract surgery. You see speculum constantly being adjusted, but definitive steps not again being taken. Let's see what is happening now. So again, this ghastly instrument goes inside rexis, go inside, go behind the nucleus, and try to retrieve this. Try to retrieve this big nucleus, but what comes out is only the rexis and not the nucleus. So only rexis has come out. So how much disturbance you have caused against section further enlargement? This is now akin to like ICC incision or whatever. You started with a small phaco incision, more enlargement. So this is just to emphasize don'ts. This should not be done. This should not be done in a patient where you have promised phaco and you see what ultimately happened to this eye. So what ultimately happened, this eye has sunk now. Spontaneous air is going inside. Now some wisdom prevails of suture karna hai. But believe me, this eye is sunk now. Sunk nucleus has gone, sunk eye, sunk surgeon. So this is what can happen if you are not very careful. So at the end of surgery, nucleus very difficult, eye gone, surgeon also in all sweating and palpitations as was being told. So what should be done? So we have talked about some don'ts, but what should be done? What are the do's? Do's are if if you are in a multi specialty setup, if VR surgeon is there, best is to hand it over. And best is retrieval, obviously in the same setting because you are accountable to the patient, to relatives who are waiting with a lot of hope outside. The advantage is same setting means you see you save second surgery, second post-op recovery, but saves your image, which is the biggest thing. That because patient immediately asks, Doctor Saab, lens dal gaya. That is what patient keeps asking the moment the surgery gets prolonged. Other do is, which has been emphasized, is if VR support is not at hand, if you're alone and you're not very confident. But today's young surgeons, I see they're very, very good and they are confident not only in doing cataract, phaco, good job, but also vitrectomy, they do a good job. So our aim should be to do a good automated vitrectomy, not with the help of swab sticks or scissors or other things. So aim should be to, as Harbans has clearly shown how vitrectomy should be done, and also emphasized by Dr. Maya also that tricot has to be the final answer. An endpoint has to be a nice round pupil. But during surgery, never put your instrumentation vertically inside. It has to be in the iris plane, horizontal, with a low flow, and you see, once you are cutting the vitreous, the cutter has to be very, very high. And good cutter should be at hand, and this has already been emphasized. And try to leave as much as capsule as possible because this may be the further support for the lens. And don't go deep inside the eye. And can insert if there is an adequate support a sulcus fixated IOL, even though nucleus may have gone behind, but put some sutures there and then immediately take help from a VR surgeon. So this was just to emphasize the tricot. I think I will skip this video, which just shows that you see without tricot, because the vitreous is a clear thing, unless there is something to stick onto that, because tricot will get adsorbed onto the vitreous fibrils and will make the invisible vitreous into a visible strand. You see, although we are sure that this has been taken, but you see the vitreous fibrils here in the infratemporal, infranasal part, and this is only visible because of the tricot, otherwise it will be very difficult. And the other point which Harbans had emphasized is that you have to constrict the pupil, then do this. So, but once it has gone behind, then I think it has to be handed over to a VR surgeon or an TS7 surgeon who can do a good job as vitrectomy. Believe me, things are still under very good control. You have to take the patient into confidence that everything is still not lost and this eye can have still very good vision. So this was again, this, you see, once the PFCL has floated, this an impalement was being done, but I am deadly against this instrumentation being put inside the eye at all. So this should not be done at all. So what should be done is shown here, although this shows a lot of cortex and epi here. So sutures have been put, 3 ports have been made, and you take care of the anterior segment cortical matter here so that the visualization improves now, and try to save as much as capsule as possible, because this may be the ultimate support. And then you see the vitreous. Today, phaco-fragmentation, you can remove hardest of the nucleus, except those jet black. Majority of the dislocated nucleus in the vitreous cavity can be removed with the help of phaco-frag. So phaco-frags are not available as a 25 gauge this thing. 23 gauge they have become available, and 25 gauge also we are hearing, but this is a 20 gauge. We had to enlarge this, and the principles are, don't go after this first do a vitrectomy around it. You see, the cortical matter is being removed, and then go towards the nucleus. So after you have done this, then with the help of same vitrectomy, you can easily tease off this remaining cortical matter from the anterior segment, taking into point that capsule you have to maintain. You see how much cornea has shows this Descemet fold, and then because the support is good enough, this vitreous surgeon can put this sulcus supported lens, and results can be good. Although the morbidity may get prolonged by a couple of weeks, but results can be good. This was another patient who had drop nucleus, and you see this cortical matter here. And since support was not much, so we were mentally preparing for this scleral fixated IOL or glued IOL, made these ports, and you see from the same ports, which are 180 degree apart, you do vitrectomy so that you don't unnecessarily make more openings inside the globe. And you take out this cortical matter first, so as to improve the visibility of the vitreous cavity. And then you do first a core vitrectomy. And as I was emphasizing, do not rush after the nucleus. First do a core vitrectomy, which is more clearly visible here. Remove this epinucleus and the cortical matter, which is sitting right on the optic nerve head on the posterior pole. Believe me, first is to, principles are to cut this vitreous first, whatever is adhering to the lenticular matter. Because vitrectomy is more important in this situation. You see this yellowish color nucleus, which we are not touching at all. We are taking care of the vitreous in the periphery. You can see the vitreous fibrils. Sometimes you can inject tricot also to improve the visibility. And then this softer part is taken out. This is mobilized. Again, because some part of vitreous is still there in the nasal part, pay attention to removal of as much vitrectomy you can do, you should do. I don't believe in the concept of core vitrectomy. Once you are inside, try to do as much vitrectomy as possible. Obviously, this does not require depression kind of vitrectomy. Again, the port is being enlarged to accommodate the 20 gauge phaco-frag. And phaco-frag initially first press is suction. If it holds it, then you can very gradually initiate the cutting part. So again, once the nuclear matter is out, then we pay attention. We got this nucleus, lift it up. It may fall, but believe me, it does not damage the retina. You can sometimes put a drop of PFCL to cushion it, but by and large it does not. Sometimes the sharp edges of this nucleus may have some hemorrhages, but believe me, most of them, although they may create some clutter inside the vitreous cavity, but slowly, steadily, this will come out, because this is a jackhammer action of the phacofrag. So if you press it too much, it will get repulsed and go back. So you have to maintain an optimal balance at how much forces to press, so that it remains sucked at the mouth of the phacofrag, and also slowly cutting also is there. So harder the nucleus, more the time taken. Softer it will come out pretty fast. Sometimes with the help of cutter also it can come out. So after this has been done, we close this 20 gauge port and then prepare this, remove this bag with the help of vitreous cutter, and prepare this eye for a skull fixated IOL, which is being done here, which I will not go into depth of it, but the principles of this, I think all of you are clear. That aim is to externalize this haptics and then put this glue. Although glue is a misnomer, glue does not do the fixation, but main job is done by this scleral pockets only. And a lot of times this question is, should IOL be inserted? Generally, I would advocate, yes, you can go ahead, provided you have adequate margin, and provided you have not fiddled with the vitreous, and provided you have done a good vitrectomy and you're not attempted fishing. These 5 photographs, which we have taken from our own photography department library, these were all patients who had nucleus drop and vitreous was disturbed and people fiddled. You see detachment, giant tears, and corneal problems, PVR, this can occur. So if you respect the vitreous, believe me, this problem can be obviated. But you see, phaco-fragmentation is very, very important, and be sure that the VR surgeon has a phaco-fragment. But a lot of times these phaco-fragment may not be available also. But in a patient who's one-eyed or fellow eyes aphakia or a dark brown nucleus, maybe you can leave the decision to the vitreous surgeon whether to put an IOL or not, and you can avoid putting an IOL, because let him do the job of the vitreous cavity and remove the nucleus first, and then if the support is good enough or if not, then he can put a SFIOL also. So just to conclude, all surgeries, not only cataract surgeries, are fraught with complications, and it happens as was being emphasized in test of hands. And our aim always is, like I firmly believe, is to learn from each of the webinars, keep improving, keep learning, so that we minimize all these complications. And if they happen, try to minimize the effect of the complications by not doing what I showed in that one big video, that all this, and ego has to be on a standby mode. And if complications do happen by chance, do not panic. Easier said than done. Pulse rate does go, sweating does start, but take deep breaths, as Dr. Maya was saying. But very important is take help, take help. And in the event of crisis of nucleus going down, basic things, respect the vitreous. Do not disrespect the vitreous. And if you want your patient or the relatives who are waiting outside to respect you, and do not want to face a situation like these 5, please respect the vitreous and do not do inadvertent murals, which can make life hell for the patient for the rest of his life. So thank you very much, Dr. Rajesh, for giving me this opportunity to talk to you. Thanks a lot.
Thank you, sir. Thank you for so many messages that you have given throughout your presentation. And what I could figure out, that it was, toned in a way that should be, presented to anterior segment surgeons. And messages regarding do's and don'ts were really, a lot of very informative, and we had a lot of learning in that. Dr. Sarvana, your comments on that?
Yeah, thank you, sir, for that wonderful library of videos. I think that experience of 35 years in VR surgery has really is showing in all those videos. I think I would just like to summarize and then add a few points. I think what we should keep in mind is that VR surgery, when done well, and when in almost good hands, can actually give 6/6 vision in all these patients if referred at the proper time. So I think most anterior segment surgeons are under the impression that once it goes to the VR surgeon, then they may not end up having 6/6 vision. So I think that concept has now changed, especially with the advent of sutureless vitrectomy. And second thing is, I think we should all advise especially the newcomers to actually do an indirect ophthalmoscopy on the table. So many times what happens is they are under the impression that they have not dropped any nucleus or they have not dropped any cortical matter. But most of them, they do, some fragments have actually gone into the vitreous, and they indeed cause post-operative complications like iritis, uveitis, and cystoid macular edema. So I think the notion that they can just assume that nothing has gone down and that they can just manage the situation with just steroids and post-operative medications, I think that particular thing should be taken care of, especially if they can do at least a indirect ophthalmoscopy on day one, if not on the table. I think they should all be motivated to do an indirect ophthalmoscopy on day one. And I think the second thing is most of them should learn when to stop. I think the juniors who are coming out now, they are not clear about when to stop when they recognize the complication. So everyone knows that something is going wrong, but they keep committing one error after another sequentially, and then finally when when the nucleus drops, and then when they are no more able to manage, then they panic. So I think they should know when to stop, when the chamber is deepening, when the pressure is reduced, when the followability of the fragments have reduced, or you're not able to rotate it as easily as what you were doing before. So I think these points, I think all newcomers who are learning surgery should actually be trained to actually recognize, so that they know when to stop, and they're not they're not hesitating to stop and hand over to a VR surgeon. And once I think we take care of these situations, I think most newcomers will be able to learn good cataract surgery without causing major collateral damage. And sir was also referring to past planar approach training, getting trained in past planar approach. I think posterior assisted levitation, if you can teach this PAL technique for most newcomers, I think it will help them, because they are all going to give intravitreal injections in future. So some amount of exposure to the pars plana area in terms of how to handle the complications, in terms of removing the fragments or removing a piece of the nucleus through a posterior assisted levitation will also help in for most newcomers. I think these are some of the few points that I thought of adding, but that was a wonderful presentation and all the videos were very good, sir. Thank you very much for that presentation.
Just one point, Sarvana, as you're talking about posterior assisted levitation, we would like to have opinion of both of you, the retina surgeons, that does it cause some amount of traction while doing posterior assisted levitation? When you're doing posterior assisted levitation, there will be some traction. So what is your opinion? What is your take on that?
Honestly, Rajesh, I'm not a very big fan of this technique because whenever this has been done, it has definitely increased the traction onto the base. So you may be successful at that time because you're not seeing much, because your focus is on the nucleus. You're not seeing the vitreous. And vitreous visibility, is not there because it's a clear substance. And as was vitreous visibility occurs because of tricot and all. Otherwise, vitreous is not visible. And you do it because you have to take it out. So that is the reason I agree with one point which Sarvana mentioned, that we should sensitize all these people for pars plana entries. That's okay. But posterior assisted levitation or PAL, I'm not a very big fan.
I think, Rajesh, I published in GCRS my technique of chopstick technique, which was for primarily impending nuclear drop. Instead of live tension, just put the chopper behind a rounded portion, lift it over there. But now at that time, in 94, 95, 96, there was no fragmentotome. We used to make a big incision and take out the nucleus in toto. It was a huge and a difficult task. So now I won't recommend that at all. I mean, there is no need. And what is the biggest?
So I'm so happy. I'm so happy that Harbans has agreed for this. That you see, greatest surgeon is that who agrees for recent developments also. You see, when he published JCRS, that was more than 20-25 years back. That time it may be okay to take two instrument and do. But today with MIVS, as Sarna was saying, you see all these things are manageable, and the number of patients who recover 696 vision is virtually universal, unless we have fiddled and done very bad to cornea and vitreous.
I think the biggest problem the young surgeons have got two. One is that who is going to foot the bill and where to send it. So my advice to all the young surgeons will be that always have one good corneal and one VR surgeon where you keep on referring your routine cases on a regular basis, so that anytime you are in a crisis, they will take care of it. You don't have to worry. I mean, if suppose you send to a corneal surgeon 10 cases of keratoplasty, tomorrow your patient needs D-sec, ask him to do free of cost, he will do it. If you send your routine cases to a VRS surgeon regularly, then whenever you are in a crisis, ask him to do at a 50%. Don't take your own cost, what you are charging for the implantation. Ask the VR surgeon to do at the same rate, and patient will be very happy that I'll go there and get my surgery done without paying. It becomes doubly problematic for the patient that you charge for the IUL, then he pays to the VR surgeon, then he's going to be very, very annoyed and very, very unhappy. So normally, though that is also true that you are admitting the guilt if you do it, but at the same time, if I commit the surgery to the patient and whatever charges can be fixed, even patient needs a second surgery, third surgery, fourth surgery, all of that is included into the package. I do not charge again, so that at least one front of the patient's dissatisfaction is taken care of. We inform them everything. This is what has happened. This is what is best for you. You can go and take a second opinion. We do not be on defensive side, but at the same time, at least we do not put on a financial burden on a patient.
But problem is everybody is not Harbans Lal.
Sir,
Sir, I had a question, sir, to Dr. Tetial, sir. Whenever, I mean, what technique has been advocated is the IOL scaffold, which we do use whenever some nuclear fragments, etc., are remaining. But when a large fragment is there, you use IOL scaffold, you're coming closer to the cornea, and I always feel that you're causing some amount of corneal damage as well. So what is your take on that?
Namrata, it's a beautiful technique to safeguard anything going behind, and which will really create another big surgery, and the stress to the surgeon and patient can be decreased. I would definitely go for that. I have used that technique in some other cases. If you can, as we discussed, if you can pick up the insult to the posterior capsule right in the beginning, so that is a time where you can take care of the entire thing. And some cases, very difficult cases where your phaco is going very difficult in a very hard cataract, the pieces are running around, and towards the end of surgery, especially hypermature type of cataract where the PC is floppy and a lot of fluctuation, you might touch the posterior capsule in these cases. There is better to be a little safer, use a IOL scaffold in these cases. And as Ameya was saying, if you have a good dispersive viscoelastic like this coat, which really saves the day for you, both from the posterior capsule as well as endothelium side also. In that viscoat cover, you can nicely do an emulsification of that piece, and that will save the day. Even you have a PCR also, plugging with the viscoat, then putting IOL, taking all the nucleus pieces to one side, as we saw the Dr. Harbans technique also. So it's a very good technique. I think it came up after the description of contact lens devices by K.K. Mehta. Then came Amar's technique of IOL scaffold, but a good one. The only thing we have to make sure is IOL in a proper position. If IOL is not resting properly, then the IOL will drop, and it will create another, difficult situation for you.
So don't drop. Okay, if nucleus be IOL.
And I think recently, Sanjay Chaudhary talks about where the contact lens is larger. So it rests on the entire iris surface and it will have much more support. So those things can be done, but these are all secondary procedures. As we discussed, if you can identify the, insult of a particular stage, then you can plan your rehabilitative surgery steps in that particular time. But never let nucleus drop.
Dr.
You can never have, people like Lalit Verma around, to help you all the time.
Professor Tetial, do you think after putting the IOL and managing the epinucleus plate, how difficult it will be? I mean, the nucleus you can prolapse into the AC, and then how to worry about the epinucleus? I'm more worried about how to take out the epinucleus. Was your point?
That is difficult, you rightly said, but there you have to really take out a vitreous, because now your IOL is normally 3-piece lens in these cases, and that is resting the sulcus very nicely. And if you have a rexis also intact, the anterior rexis, then you can do a vitrectomy, take out the vitreous, then do a aspiration slowly, the entire cortex, epicortex in these cases, with the biscote cover in the between. So that is how. And if you have little bit of remaining cortex, you can leave that also. Wait for some days. Sometimes it hydrates and floats into anterior chamber, or sometimes they are so less that they get fibrous also. So don't try to do too much of aspiration in these cases without visualization of vitreous in the anterior chamber. So rightly said, if you stain the vitreous, do a vitrectomy, then with the same vitrector, you can go to aspiration mode and keep aspirating and eating.
I personally feel that the white Morganian type of cataracts, they are very good for the IOL scaffold because there's nothing behind.
Yes.
And if you are going to do the epinucleus, then you have to be comfortable going through the pars plana, because if the infusion is from the top, as soon as you open up a little more capsule, the epinucleus will drop down. But the infusion has to be from the back. So I feel that I have dropped more epinuclear plate into the vitreous cavity than nucleus, because nucleus you can hold. So whenever the epinucleus is there, which is large enough, you can't hold with anything. So if infusion is from the back, it won't have that much of tendency falling into the retina as compared to when the infusion is from the top.
But I believe that most of the patients where you have used IOL scaffold or contact lens scaffold, ultimately, although it may be a small vitrectomy, but vitrectomy is required in a lot of these patients, secondary procedure. But at that time, you have managed it well. So as I said, I don't mind IOL being put, but vitreous has to be taken. That will require a second surgery.
You're absolutely correct. I have, in fact, it's easier to get the epicortex onto the IOL in these cases. You can just put the IOL to one side, get IOL below, and the entire epicortex floats onto the IOL surface. So you still have a support for even for our epicortex also, and that can be taken out very nicely.
Yeah, that's what I also feel, that epinucleus also has to be brought anteriorly, and then the IOL should go behind, because if you keep the epinucleus and then only keep the nucleus ahead and epinucleus is behind, it will fall. So epinucleus should also be manipulated and brought out. And I've also that use of this vitrector in removing the remaining cortex is very useful by by cut IA mode and IA cut mode, and that way you can have a good control of the removal of cortex.
I agree, because sometimes this cortex may be admixed also. You see, admixed, so cutter does help. You see now with MBR plate, if you make a side port, and this 23 gauge cutter can easily go and easily come out.
The thing is, when you have the IA cut mode, if you irrigate, aspirate, and then unknowingly you go into 3, and if you are close to the anterior capsule or posterior capsule, you may eat off a lot of support which you have already had. So that we have to be very careful with when we are using the
True.
So one question I should ask all of you: how many of you actually, Harban's made one statement, drop the nucleus into vitreous in case?
No, actually, actually, he made
this is a very bold statement, but I don't think anybody will, do this technique with Pisheja.
No, Lalit, what I mean to say, if you need to clear, there's some tilting vitreous and you are not able to clear the vitreous and you are not able to put the IOL and that is disturbing you. So we are surgeon in any case, I mean, for him, it makes no difference where the vitreous, the lens is in the vitreous cavity, whether it's onto the retina or into the anterior part. He has to do vitrectomy, only then he can remove the lens.
No, I agree. No, it's not for me. What I'm saying is anterior segment surgeon, how many times they actually do this technique of couching over this.
Not couching. It is perfectly sound and sight. It's only your mindset that you feel you are doing something wrong. Instead of taking it out, you are putting it in. But actually, you are helping because you'll be able to remove whole of the cortex. You'll be able to clean up whole of the anterior segment. You will be able to put the IOL. If that the doubt in your mind, I should take out the nucleus, I should take out the nucleus to take it away from your head. Let it be very clear that the VR surgeon is going to take it away.
I agree. I just wanted from this lighter mode of it that just to make.
Actually, you need to promote it.
But I think
this is wrong notion.
Yeah.
You have to take it out from the front only.
Only thing is how to face the patient. The issue is that because once these things happen, facing the patient and relatives is a big challenge. So this is where the issue comes. But in any case, I'm happy that one thing that Sarvana and Ilan and everybody emphasized, and Harbans also emphasized, that all surgeons should learn anterior vitrectomy and do not depend on this, that rectis and all for this. So automatic anterior vitrectomy 23 gauge should be there in the OT of everybody. And no harm if you can't enter this phobia, your phobia of going from pars plana, at least AC should be clear of vitreous. That should be there at least. This also minimizes, so this should be a take home for everybody that in the event of all this, please do not disrespect the vitreous. That's it.
I think Lalit, facing patient is not a problem at all if you are confident and you are truthful. Two things are very important. Whenever the complication happens, never look like that if you have done something wrong. There should be no feeling of guilt, complication and a parcel of a surgery. You should be confident when you are talking to the patient and tell the patient immediately what has happened and what can be done, and you'll be all right.
No, I made this statement primarily for younger. I made this statement primarily for
single word from the patient so that I am at ease. Because if you do not tell the patient can read your face that something is not correct.
No, I agree. You see, what I'm saying is the reason I made this statement was for a younger colleague, for a novice, it will be difficult. But people with white hairs and bald head, they can easily, counter the patient. It's very easy because they have done so many good surgeries also, 10,000. But one odd. But what I'm saying is for a younger colleague who has just started, it becomes very, very difficult. It becomes very, very difficult to face the patient. Because, that is the issue.
Just a one, I think request to all of you, what should we be saying to the patient at that time?
So what I tell even in patients of detachment, endophthalmitis, that talk to the patient, talk. I'm very fond of, patient, all with relatives sitting at one place. I will tell them that if you cooperate, things are salvageable. Everything is not lost. There has been some issue. Like Harbans was saying, kuch uneventful hua hai, because 100 में से 100 number मेरे भी नहीं आते. I can't succeed in all predictable surgeries. So one odd things happened, but if you cooperate, we will make it, good seeing eye for life. So you have to seek cooperation from the patient and relatives. And believe me, one of the relative or one say, "Nah, that's sab theek hai, aap karo." So that is important to talk and talk. Don't hide, like Harbans was saying. So talking is important by the primary surgeon, jiske paas patient aaya hai. Not by the resident and not by your assistant or somebody. You go, take off your gown, gloves, talk.
I think that's a very important point. Like the primary surgeon has to face the patient. But I was just asking, many people have different ways to convey what has happened to the patient. The most common one is, your posterior capsule was very weak. So that is the most common thing I've heard. And second, they say you coughed on the table and that's why it has happened like this. You moved very, undesirably. Third, they would say, well, somebody, pushed me, suddenly I think we have to be truthful there, to tell them exactly. But that is what I wanted. Lalit answered beautifully.
Thank you, sir. Wonderful messages, wonderful discussion, wonderful talks. And sir, Titial sir, would you like to make concluding remarks?
I think we have concluded most of the things, and today's session I think must have been the most useful, in the entire the series of Fridays we have used. This was common. Everybody faces these problems, and it shows that we require a friendship, not only with our patients, but also with our colleagues, so that we come handy in a difficult situation for each other. As nicely pointed by Lalit, you need to have, Harbans, one cornea-friendly person and one retina-friendly nearby person, who can handle these issues faster. Giving an example of our center, where the largest number of people are training at a given time. And to my surprise, nowadays, for last few years, I never come to know what has happened in the operation theatre. By the time we realize that nucleus is out and lens been put and patient is happy and gone out. So that's the expertise of our residents also. Within a fraction of a minute, they are there. And by the time we realize, sometimes you see suddenly darkness in the operation theatre. Then I realize that something must be going on. So that has been a good training. Like you are talking about, people should be trained in a past planar, or agents are trained now in every field. So that's a good way we have gone into. Like not only the high-tech instrumentation machines, they also do all these procedures also. And most importantly, they should realize that things can be salvaged, not on the table, maybe tomorrow or the day after, maybe 1 week also. If they learn this, they will commit less complication of the complication. I think that is what we have learned today also, and people would have realized. I think it was a very nice session, and especially input from a expert like Dr. Lalit Verma, Dr. Harbans, Minu, and the commitment of our panelists. Though they are young, most of them are very young, but their contributions are great. Amay, Rajesh, and Sarvana. I'm seeing Sarvana after a very, very long time because conference is off now.
We see him very frequently, sir. We see him very frequently.
Yeah.
Yeah. You people are
at all the other platforms.
Yeah.
Rajesh and Navata are omnipresent. They are in a cloud. Nobody can miss them,
No.
We are in a one segment only, either in the cornea or a cataract refractive. You are everywhere. That's great.
But Sarvana today made four comments. All four were very, very nice.
Yeah.
And Elan also,
No, Sarvana's comments, I know about his comments.
They are always very nice.
Very strong and meaningful. So
I'm talking scientific comments, and this which was very, very nice. Elan contributed, and Amaya made some very useful comments, and
great.
And Minu's videos as usual. I'm always amazed.
Normally, Rajiv doesn't ask any question. Today he had questions also. That's
So in the end, I would like to thank all the speakers and the panelists and our support staffs, Anil Kumar, Bhageshwar, and of course the IT team of IPCA for their support. So thank you very much. It was a wonderful session, wonderful discussion, and a very good night to all of you. Hope to see you again in some of the webinars, which are again very interesting.
Okay, bye. Thanks, Rajesh, for everything. Thank you, Elan and Sarvana, Amaya. Nice talking to you and interacting. Rajesh, Joshi also.
Thank you, sir.
Thanks a lot. See you sometime.
Bye.
Thank you.
Bye. Good night.
Bye. Good night.
Good night.